stretch, your capsule is stretched. So
Sorry,
you
Murli,
have it a wrist.
Murli, what's the question?
So can we do a posterior capsulorhexis after placing the modified Sioni ring?
Sure.
Yeah.
Yeah, you answered that.
Yeah, the capsule is not fibrosed, not fibrosed. Do not attempt. You may not have a control. Your axis can actually, off center or can get extended to the equator. Then it causes complications.
Yeah, Murli, the problem is what you're using is 10-12 is the smallest size you have, and if you do a UBM of these patients, you realize the bag of Indian kids is never more than 9 millimeter. 9 is on the higher side, but 6.5 to 8.5 is what we're getting. So if you got 10-12, the rexis is under stretch. So when you put a CTR or a Sioni, it's under stretch. So the moment you give a neck, it will try to run off. So the trick is not to overfill these bags. You overfill this bag and then do the posterior, it will run off. But if you can titrate the viscoelastic, make the chamber deep, but the bag should be flaccid. Then you can get away. I've done few patients, but otherwise you can avoid. But the good thing was that if you put it, it's better, because if you put Sionis and you got a knuckle on the top of the rexis, it will pull the lens anterior. So your square edge of this single piece is not going to work. So your chances of VO formation is high. So if you do a PCC, I think it makes sense. But you got to be careful in that one. All right?
So just two questions. One, the persistent pupillary membrane, you said it's most commonly bilateral. How often have you seen it to be unilateral? Persistent pupillary membrane, because I have a child which has a dense persistent pupillary membrane in only one of the eye. Post surgery, she has a very high myopia in that particular eye which is operated, which is a little different from what you mentioned. It's bilateral and hyperopia to be the most common.
I'm sorry if I've conveyed, it's a bilateral, it's a mostly unilateral, about 70% of the time. So only 1/3 of time, it's a bilateral.
But you mentioned hyperopia, I think that's, so basically what is happening is, it's basically a PFB. It's the anterior part of the persistent fetal vasculature. So when the blood comes from the back, it comes anteriorly, and when it retracts, it goes from the anterior posterior. So this one stays there, and you can have these processes which are there. But PPMs will be mostly unilateral. And if you see, the anterior subcapsular cataract is what you get, and that is central 2.5 or 3 millimeter. Not all the patients will have cataract. So your unilateral patient could be myope, and this one that goes in hand. That's okay. Second question now.
Second question was, do you always suture the side ports which you have made to insert the iris hooks, as you showed in case scenario 4?
Not necessarily, you just have to take a call based on, how well, the seals up at the end. You can actually do a stromal iteration and see. And particularly those side ports, they are very tiny, the stab wounds, they are much lesser than 1 millimeter. So you have any difference?
The thing is that when you're making a side ports for the iris hooks, you're never going vertically straight. You're going like a bevel. Because if you go straight and you pull the iris out, it will be making a stretch there, and your probe will touch always. So never do that. You have to pull it at the physiological plane. So you come from about 2 millimeters away from the limbus, go at a slant. So if you're going at a slant, you already got a beveled incision. So they'll seal on its own. So in case there's a ooze from there, blood going inside, that can happen. Then you put in a bubble, hold it for a couple of minutes, and then take it out, it'll stop. But always go at an angle. If there's a dome here, don't go straight inside, go from the side. Come parallel to the iris. So iris hooks should be coming parallel to the iris, not pulling the iris anteriorly into the chamber. All right?
Thank you.
General rule is that, my threshold to suture is extremely low. It's always good to suture them, right?
I just asked it because in that particular video it had sutures in all the side ports which you had used for the iris.
Yeah, I'll give you a trick there also. So it's a trick called dynamic bubble in the chamber. You make a bubble in the chamber, you always suture the main incision, and then you hydrate the side ports and look at the size of the bubble. If the bubble is expanding still, that means that the aqueous leaking and the bubble is becoming bigger. Please suture these ones. And if they're not expanding, that's what I do for last 20 years. And if they don't expand, leave them alone, nothing will happen. Okay? Murli, I think I showed the last time the dynamic bubble thing. So that one should do.
Right, we'll go on.
KAZI? Yeah, sure, all yours.
Good. Good morning. And I must say thank you to AIOS for inviting me and give the opportunity to talk here. And whenever I'm beside Professor Coker, I'm really afraid of presenting anything. But at the same time, I'm very happy that each time I visit and he is with me, I'm with him. I learn new things to take back home. I'm going to share a few of my cases just to present that I wish I did not do the case like that. Maybe get some tips to correct myself here. And pediatric cataract is always difficult in our setting, and you don't get a lot of support and instruments for the pediatric cataract that you get for the adults. And I do not have any financial disclosure here. And this is the first case that you can see the quite big defect can be seen in the posterior capsule right before you start the surgery. And I do a little bit very gentle hydration, and then if you can take all the cortical matter out, but you have to assess that what is the big defect is there, and what is the contracture of the posterior capsule adjacent to the big defect. And if this big defect is, if you think this is quite good enough that you can put a single piece lens in the bag, you can do that. But many times we have to be very careful, because sometimes the adjacent area of this big defect is not really strong enough to hold the lens. But that is a big issue that we should really take care. And doing a little bit vitrectomy is always mandatory. And sometimes I do it after the lens when I think that it is safer to put the lens first, then do the anterior vitrectomy later. You see, in the next case, a very nice anterior capsulectomy was done. The lens matter was quite strong enough, so I used my phaco tip to take this strong, the hard cataract portion out. You can see a very small posterior capsular defect is there, and that was so small I thought this is nothing, that I can put a lens into the bag first. But I thought I should be very careful, and then I tried to dial the lens. After introducing the lens, you see the lens is shrinking into the vitreous cavity. So the lens was immediately recovered. The identification of the problem it is important that you should not really waste any time. And that the lens was recovered in the anterior chamber, and after long fight, the lens was placed into the capsular bag again. But you see, such a small posterior capsular defect can give you a lot of trouble. But finally, how you manage is the important point. Now, this lens is centered, optic is centered, and lens was well fitted. And such a big defect was there. And this is a very simple case, and putting a lens into the bag, secondary IOL implantation, placing the single piece lens into the bag. And I did this at the age of 3 months, and when this baby came back after 4.5 years, so I planned to put a single piece lens into the capsular bag. You need to open this bag and clear all the cortical matter from different angles, from different direction. And whenever the whole volume of the cortex is being reviewed, and the bag is free from the cortex, then you inflate the bag with a viscoelastic, and then you try to put this single piece lens into the bag secondarily. And if it is not possible, we can place a 3-piece lens, but if it is possible, I prefer to put this lens in the bag and well centered in the bag. And this is a traumatic cataract, and this clearing the posterior synechiae was quite difficult, so I used lens hook. And because the intralenticular pressure was really high, AC was very shallow to work out, so I decided to take the loose cortical matter out from the lens, but that was not really very easy, and it was quite difficult to take this loose cortical matter. Now you see a little bit black area, so significant cortex has been aspirated, so I can get a better room to work out. But this anterior capsule was so difficult to maneuver, and I used different scissors to cut and make a nice anterior capsulotomy. and you can approach from different direction as you look as you like, then take this cortical matter out. You see, that was a very, very dense cataract, and after clearing every cortical matters from the bag, and the media is becoming clearer, and you can really take all the cortex from different angle, and do not forget to do the posterior capsulotomy and anterior vitrectomy. Then you can put a lens in this difficult case as well. But this many case that we see that maneuvering in the anterior chamber is difficult when it is really, really shallow. Sometimes I'm behaving like in UK doctors, putting a lens first and then do the vitrectomy. But sometimes whenever I think it is comfortable, I do that. Now this is a traumatic as well. There is a band. There was a publication. It's called band technique. But I don't like to disturb this band. But you see, this I caught this here. I caught this posterior capsule. So putting the opening of the vitreous cutter down is really, really risky. Whenever you put it down, you can really catch this posterior capsule. But you have to be sure that you can identify the problem, what you have done. Now you see that freed. And I cut the vitreous whenever I need and use this aspiration port of the vitreous cutter mode to take this cortical matter out. And clearing everything, every corner, and this posterior capsulotomy was done, and also lens was placed using this band as a scaffold so that the lens optic can be centered for future. See, nicely placed, because some part of the iris was lost because of that trauma. And this is a case that I started with a very nice anterior capsulotomy, and then the cortical matter was really stuck with the capsule. It was really very tough to remove, so I was a little bit harsh to clean this cortical matters from the capsule from both the direction. So see what I did. Can you see this? So I toned some sort of zonules here, and the zonules were, this is a significant area that I damaged here. So now what to do? So I identified the problem, and then try to reposition, but it was quite big. There was no other option without putting a capsular tension ring. So doing something a little bit harsh is not really advised. We have to be very gentle, and doesn't matter, it might take a little more time, but it is always safe to complete the surgery without any disruption. And then after putting that capsule tension ring, when you put the lens, the capsule is the capsular bag is now well set, and the optic is in the center, and clean the capsule. So you see, now after managing this case, is well centered. Now a very interesting case is the lens was well fitted into the cartridge, and then it was placed and it was observed everything was in order. But when I introduced the lens into the anterior chamber, suddenly I found that half of the lens was missing. I rewind my video where I did that mistake, but you see, I had to wait for about 45 minutes for the second lens of the same power. This power was not an usual power, so I always advise that a second power we should always keep in our hand, because many power are not really very common powers. With this, I really like to end my talk. Thank you very much.
So wonderful, Kazi. So you've seen how Kazi handles this thing. So see, the problem is similar.